Okay, so back to chapter 26, the renal system and actually renal issues. We're going to go through assessing a UTI patient teaching, pyelonephritis, urethritis, diverticuli, cystitis, and renal TB. Um, these are all fairly short, so we're just going to go over a brief summary of each of those. What you do need to pay attention to is the assessment part and the patient teaching part. All right, so let's start off with assessing for UTI. When we're assessing for a UTI, we have to remember that we're looking for not just lower urinary tract symptoms, but also upper. So we have, of course, subjective and objective data when we're assessing. So assessment, assessment. All right, so for subjective data coming from the patient, we are looking for dysuria, pain, incontinence, fever, chills, even dysuria. Okay, so we are looking for all types of different things, but specifically the symptoms or manifestations that we are looking for are going to be the incontinence, the dysuria, the urge to urinate, um, the pain during urination, and then you're looking for the systemic as well. Systemic being your upper urinary tract symptoms, which is fever, chills, nausea, vomiting, hyponatremia. You also need to assess medications. So medications that we're looking at our anticholinergics. We're also looking at antiplasmic, and our antibiotics, of course. Antibiotics. Okay, so anticholinergics, as you know, is going to prevent urination in a lot of ways, which can lead to the infection or backflow. You also have antiplasmatics, which is actually, it prevents muscle spasms. And for that reason, you might not have the bladder empty completely, and then urine kind of started to build up where it has the risk of producing bacteria. And again, remember that this can be caused by bacteria or a virus, but usually it's E. coli, which is, of course, bacteria. And antibiotics, so if your antibiotics are completely wiping out everything that you have, then you have that risk of creating different types or being immunosuppressed. So you have that problem with some of the antibiotics. But pretty much anything that causes retention, anticholinergics, or issues with urination. We also need to look at what are the patterns like. So are they having to hold their bladder for a long period of time? Are they having sex with random people? That creates the risk for STDs, which of course creates the risk for urinary tract infections. We're also looking at nutrition. So are they drinking enough water? We're recommending 8-ounce glasses of water. So are they drinking enough water, or maybe they're taking in a lot of, sodas instead of, juices and waters. We're also looking at the frequency or prior history of UTIs, and of course any surgeries that relate to the renal system itself. Pregnancy is going to be a big risk as well, because that has a hormonal shift and it really creates issues. So STDs, pregnancies, prior history, med, your medicines, and then your health patterns themselves. Health patterns being hygiene, wiping from front to back, making sure you're clean, things like that. STDs, or just having sex with random people. And then urinary. So are they having to hold in their urine? Or are they able to go frequently enough? What is their urinary pattern? All right, so that's our assessment as far as subjective. Now, objective. And again, we're talking about UTI in a broader sense of lower and upper. So objective, we're looking for a couple of different things. one, we're looking for, you can of course assess your fever, your hematocrit, or hematocrit, your hematuria. But we also need to be looking for palpitation, look for those enlarged kidneys, and that might be also good assess for that CVA or your costoventricular angle. That's the back side of your lumbar where your kidneys are located, so you're looking for pain there. Also smell, and of course smell always means that, well, or I guess not always, but it generally means that there's bacteria. So if we have smell in urine other than what urine should normally smell like, well then we have a good sign that it might just be bacteria. So smell, of course we're looking for color, and color it should be clear instead of cloudy. Cloudy indicates you have blood in your urine or hematuria. We're also looking for, that's another one I want to talk about, white blood cell cast. Okay, so why is this important? And what does this mean? First of all, a white blood cell cast, a cast in general, is kind of sphere or cylinder in shape. Cylinder in shape. But what's most notable about these casts is that they come from the distal tubule in your kidneys. So when I say cast, we are automatically thinking tubules, kidney. We're not thinking, hey, this is in the ureter. We're not thinking this is in the bladder. We know that it had to start up in the kidneys because that's where they are. So when we say cast, it could be a red blood cell cast, it could be a white blood cell cast, it could be a lot of different types of casts. But when we're talking about it in this sense, it has to come from the upper urinary tract. It has to come from your tubules. So that's why that's significant. And that right there is going to tell you, hey, I have this type of infection usually. Of course, you want to go on for sensitivity testing and things like that, but that's a good sign. And objective. So that, again, there's a lot of other ones, but these are I wanted to mention this white blood cell cast. And of course, you're going to get your diagnostics done. So you're going to go take it to a UA and identify whether or not you might have white blood cell cast or bacteria or blood in the urine, things like that. Okay, so that's the assessment part. The patient treatment. Patient treatment, of course, is going to be, and I think this is rather self-explanatory, but anything as far as nursing goes, you want to make sure that you go over, one, your assessment, and two, teaching, because teaching is a big part of it. So teaching is the other area. So teaching, what should we be teaching? One, plenty of water intake, and I said that before. You can take the weight of somebody and divide it in half by 2, and that's how many ounces that you should get, or just 8 glasses of 8 ounce water. So proper nutrition, proper hydration, that could be important. Hygiene, make sure that people are wiping front to back, make sure that they're cleaning themselves with soapy water. Not using vaginal sprays, staying away from sexual intercourse, or any introduction of outside body. And bladder emptying, that's an important, bladder emptying. So empty the bladder all the way, so that we don't have urine sitting in there. And cranberry juice is the other one. You can use cranberry juice. So 8 ounces 3 times a day, or the pills, that'll work as well. And antibiotics, of course, make sure you take all of them instead of just until the symptoms are gone. So that's your basic patient teaching. Of course, you need to make sure that you remind them of reporting. If, for instance, if it started off with just a lower, then you're not going to have your fever chills, or you're not going to have your systemic reactions. So patients need to be aware of what the symptoms are for systemic reactions. That feeling of just being not feeling well, fevers, chills, nausea, vomiting. They need to know those so that way they can report back to their doctor and try and treat the then upper urinary tract infection. All right, so that's assessment, patient teaching. So pyelonephritis. All right, so pyelo, in this of kidneys, nephrons, inflammation. All right, so we have kidney nephron inflammation, and it talked about the acute and chronic pyelonephritis, and the it references this, so I'm going to go over this. Parenchyma. Okay, all this is the functional part of something. Right, in our renal system, the nephron is the functional part of our renal system. So when we see parenchyma, they're talking about nephron. This does not mean that it doesn't include your other areas as well, your collecting areas, but it just means that this part is inflamed, and that's the functioning part. So this word itself is just the functioning part of a unit of an organ. That's all that means. All right, and as far as the renal system goes, we're talking about nephrons or collection fluid. The causes are usually, and the treatment and patient teaching is going to be very similar to your UTI. But your cause is going to normally be bacteria. It can be, of course, of a viral nature, but it's usually bacteria. And it starts. Right, starts in. It usually starts in your lower urinary tract, and then goes up. 90% of the time, it's going to go up from there. So it'll start low and then go up because we just are susceptible to more outside bacteria at that point. The other problems that you can, or the other reasons why you can have this is There's a review right there. Yep. Reflex. All right, let me break this down real quick. All right, so remember they refer to the bladder as a vessel. So that's bladder. O is going to, and ureter is of course your ureter. Reflux. So what does this mean? So we are going from, here's our start point. We're going from the bladder. Here's our going to ureter, which we know is not correct. It should be going ureter or bladder, but anyways. So it starts here and it's here. That means that we've got urine going from the bladder back into the urea. And that, of course, is going to create an issue. But anytime you have that O in there, it's going from one, it's starting here, it's going somewhere, and it ends here, okay? That's all that means. So it's very simple if you just break it down. All right, the other cause is obstruction. So if I have a kidney stone and I have a buildup or the holding of the urine, then that's going to cause this pyelonephritis. But again, remember, it is the inflammation of your functional unit, your nephron. All right. The other part of it, starts in your upper is called acute. So that's pyelonephritis. Acute pyelonephritis, of course, we know the word acute means quick onset, serious. So acute, it just quickly came on. That is going to start in the upper I'm so used to writing L right there. Your upper urinary tracts, your upper tract. And this is going to generally start off in the medulla of your kidney. If you remember back to the kidney, we have the kidney, all right, fluid comes out and it goes into the ureter. All right, so if I were to say your medulla, we know that medulla means middle, so the middle area. of your kidney, whereas your cortex is going to be the core outside, or the crust. That's the way I think about it. Anyways, it starts in the medulla, and that means it's going to start from your upper and go into your lower. You're going to have those, when you have the upper, you're going to have those fever, your systemic reactions, chill, nausea, vomiting. Those are systemic reactions. And CVA. Okay. Alright, the diagnosis for this is going to be a UA, which of course can be, you start at that UA, or a dipstick test, and then you can go from there into a sensitivity testing, or if you're, pretty sure that it's going to require a certain type of testing, then you can go right into it. But UT or any of your RAD diagnostics. So that's any of your contrast diagnostics, MRI, sensitivity. At this point, this is pretty serious at this point. So you want to make sure that you start treating it with something. Just start treating it with something. So what is some broad antibiotic? Amoxicillin, just start treating it with some general antibiotic, okay? And this they refer to as empirical, which basically means that I'm using my knowledge base instead of like actual data. It means that, hey, I know this is something wrong. I need to use some type of antibiotic. I'm going to just pick a general one, amoxicillin or ampicillin, or something of that nature. Of course, you can have NSAID. Now, remember, there's nephrotoxicity with NSAID. So, non-steroidal anti-inflammatory. Yeah. There's nephron toxicity, so that's important that you're making sure that they're actually urinating. But so start off with just something. This is serious, so they just need some type of antibiotic. Throw it at them. Once you get that culture back, which you should have a culture on this. Once you get that culture back, then that will tell you, hey, it's specifically this type of bacteria, and we need to treat it with this type of thing. From there, you can go into your Cipro, or your TN, and I might tend to say that word, TNP or Cipro, or one of the other ones. And again, your patient teaching is going to be very similar to your UTI, and will, excuse me, and diagnostic as well, or your assessment as well. So the UTI can kind of be used throughout this one. All right, now of course that was the acute. So you had the regular, then we went through acute, now we're going to go through chronic. Chronic is the same thing, except it takes a long time, or it's been persistent. And at that point, you're going to have scarring. That's your biggest factor. When you have that much inflammation for that long, you're going to end up with scarring, which is going to cause a reduced urine flow usually. So I believe is the word they use, but just basically think of constriction, or restrictor. So you're going to have scarring. It's usually caused by lots of UTIs. And of course, your diagnostic at this point is going to be some type of bad diagnostic, so give me some contrast, or a biopsy. Usually from here, you're going to go to end-stage kidney failure. But there's at this point, you've got scarring. So it's going to continue to reduce the amount of blood flow it's going to get, and it's going to continue to build up. Alright, so that is pyelonephritis, inflammation of your nephron or functional unit of your kidney. And my question was, of course, what was the difference between the UTI and pyelonephritis? And the difference is that the UTI, one, it can have the bladder and or kidneys. But when you're talking specifically about inflammation of the kidneys, you're talking about pyelonephritis. Alright, so a UTI can create pyelonephritis. Pyelonephritis can cause a UTI, but UTI is specifically your bladder and or kidney, but generally the bladder. Alright, so the other one that we're going to hit on is your urethritis, and as you might guess, it's inflammation of your urethra. Beautiful, usually caused by an STD. For males, Females also, but females are harder to diagnose. We're not going to hit on this too much. It's very often going to look like UTI symptoms, and you need to figure out exactly what it is. So if you have chlamydia or you have some type of STD, they need to figure out what the STD is so they can treat the STD. But this is just inflammation of your urethra. And again, your symptoms look very much like UTIs. But you've got to figure out what it is. Also, your patient teaching is still going to be drinking water, especially with an STD, you should not be having sex. But so that is urethritis. Urethra diverticulitis. If you're even remotely familiar with diverticulitis, we usually say, diverticulitis, we almost always think of GI, but here it's the same thing. It's a pouching, so it's just where the body is pouched out. So you've created these little pouches that things can go into, and of course, we know it usually as foods building up in here, or some other type of substance, and that's going to create bacteria and infection. There really is not a good treatment for this. It's higher in women, and it's usually caused by trauma, childbearing. The difference is that they might feel like their bladder is not emptying all the way, and it really isn't because it's in pouches. But and then of course also the UTI symptoms. So your diagnosis, you're going to get this diagnosis from palpitation. So you can literally go in and feel it. Or of course, you can always do contrast scan, ultrasound for your diverticulitis. But your treatment is pretty much surgery, and that's really going to be about it. Because at that point, you have pouches in your urethra or in your ureter. So that's going to be about all you can do there. All right. So pyelonephritis, acute, chronic, and just pyelonephritis, the inflammation of the nephrons, urethritis, inflammation in the ureter or urethra, usually caused by an STD. Urethra diverticulitis, that's pouches formed in your urethra. Again, only thing you can really do for that is surgery, and it's usually caused by trauma. So now we're on interstitial cystitis, and when we say this word, we're going to talk about inflammation of what? The bladder. So this is an interesting one because pretty much this is the fallback for if I have tested you for everything, I can't figure out what you have. This is the fallback, right? So it's this interstitial cystitis, and because it's the fallback, is idiopathic, and idiopathic means, or the way I remember it at least, it means you're an idiot if you can't figure out the cause. So they don't know the cause. But it manifests itself with many of the symptoms that are similar to UTI. You're also going to have you're going to have your suprapubital or pain above your pubic bone. But this pain can spread all over to your entire peritoneal area. It is aggravated by extended bladder. Usually helps by emptying the bladder. It can be aggravated by stress. It can be aggravated by sex. It can be aggravated by menstruation or premenstruation. And of course, because there's not really a known cause, we can't really treat something by a cause. So at that point, you're treating the symptoms. So you might have your NSAIDs, you might have, pain relievers, things like that. So when we go to diagnosis, again, we're testing, we can't find a cause. This is something that is diagnosed out of process of elimination. So when we've eliminated all other possibilities, this is what you have. And the abbreviation for this is actually right up here somewhere. ID. I'm not finding it. Oh, PBS. So painful bladder syndrome, or ICPBS. ICPBS, painful bladder syndrome. That's the other name it goes by. The diagnosis. So your bladder wall might be irritated, and of course, if you have long-term irritation, you have inflammation, and you eventually can produce scarring. You also have bleeding, which will come out in the urine. And it's usually diagnosed wrong. It's usually diagnosed as a UTI, or recurring UTI. So it will probably be treated wrong as well. Your best treatment for this is to try and figure out with the patient what types of foods and irritants to avoid, ways to manage stress better, ways to possibly reduce irritation during sexual intercourse. You are looking to prevent whatever causes it, because we don't necessarily know how to treat it. So you're looking for those irritants, alcohols, spicy foods, peppermints. Now you can take, again, things to treat the symptoms of it, or that relieve the pain of urination, things like that. So there's some that can relieve the pain or kind of coat the bladder, but that's about all you're going to do there. And that is your ICPBS, or interstitial cystitis, painful bladder syndrome. Completely idiopathic. We have no treatment for that one. We're treating the symptoms. All right, renal TB. So renal TB, all right, basically it goes from the lungs into the renal system, and this process takes about 5 to 8 years, and it can be very asymptomatic. You would have to actually get the TB in the UA, because they're going to test positive for being exposed to TB. That doesn't necessarily mean that's what's causing it. But renal TB is where the TB is spread from the lungs into your renal system. It takes a long time to manifest itself, and it can be very asymptomatic for a while. The treatment, of course, for this is going to be treating the TB. All right, and I won't go into that one, but that's your treatment for it. The renal TB also, it can look like a UTI, so you're going to have to actually get positive TB findings in your urinalysis, and not just in the patient, because the patient's already been exposed to TB. So, all right, and that's going to summarize the minor parts of chapter 46. Just the assessment and the teaching patient was the most important idea. So those are the ones you need to be focusing on. All right, and